Everyone, today we're going to cover COPD, Chronic Obstructive Pulmonary Disease. So what is COPD? So it's a chronic respiratory disease characterized by airflow obstruction and gas exchange abnormalities. So the air gets trapped in the lungs and can't get out efficiently. So the main causes are tobacco smoke, is responsible for 85 to 90% of cases, but air pollution and occupational exposure also contribute. So there is also genetic form, alpha-1 antitrypsin deficiency, or AATD. So if there is a young patient with COPD who never smoked, always think of anti-1 antitrypsin deficiency. The pathophysiology involves chronic airway inflammation that progresses to emphysema, that's irreversible destruction of alveoli, causing hyperinflation and loss of gas exchange and surface area. So this leads to hypoxemia or low oxygen and carbon dioxide retention. So how does COPD present? The classic features are progressive dyspnea and a productive cough. So usually the patient coughs up sputum, often in the morning. So this is chronic, not acute like asthma. So in advanced disease, you'll see tachypnea, tachycardia, cyanosis, that bluish discoloration from hypoxemia, and the classic barrel chest from hyperinflation. So patients often purse their lips when breathing out. This creates back pressure to keep airway open. So another sign, using accessory muscle to breathe with tripod positioning, where they lean forward to help breathing. So diagnosis requires clinical presentation plus pulmonary function testing. So on spirometry, the hallmark finding is a reduced FEV1 to FVC ratio. So specifically less than 0.7. So FEV1 is forced expiratory volume in 1 second, and FVC is forced vital capacity. Unlike asthma, this obstruction is not reversible with bronchodilators. That's the key difference. So we also stage severity based on FEV1 present predicted. Mild is over 80%, moderate is 50 to 80, severe is 30 to 50, and very severe is under 30%. So chest X-ray or CT shows hyperinflation, flattened diaphragm, and bulla. So we also check arterial blood gas, so to assess, which is ABG, to assess hypoxemia and CO2 retention. The treatment starts with the smoking cessation. So this is the only intervention that slows disease progression. For symptom management, we use bronchodilators, short-acting for acute relief and long-acting for maintenance. So adding inhaled corticosteroids for frequent exacerbations or severe disease. So for advanced COPD with chronic hypoxemia, long-term oxygen therapy improves survival. So some patients need non-invasive ventilation like BPAP.